My name is Michael. I come from King's College London, and today I will talk to you about cognitive remediation therapy for people with bipolar disorder. So my talk will go over those 4 questions, and we'll try to provide some answers. So let's start by discussing the rationale of cognitive remediation therapy. So people with bipolar often experience cognitive deficits across different domains, and these are more pronounced during the episodes, but then can persist in remission. So this means that mood symptom recovery does not always translate into functional recovery. However, at the same time, people with bipolar are often very, very heterogeneous, which means that there are different cognitive clusters. So not everyone with bipolar experiences the same magnitude of symptoms. We have people with some very minimal or no impairments, some with more extensive ones, and some with the most severe neurodevelopmental course of the condition. And at the same time, some people tend to recover following episodes in terms of their cognitive functioning, whereas some do not and progressively become worse. And this is important because cognitive functioning can also impair daily functioning, someone's capacity to work, quality of life, and this can contribute to the burden of the condition. At the same time, there is some evidence, early evidence, that show that cognitive impairment could also predict mood symptom occurrence. So people with greater deficits at baseline or before the illness onset could have a worse illness prognosis. And interestingly, the association between cognitive and psychosocial functioning is independent of residual depressive symptoms. So there's some systematic reviews that have highlighted the need for pro-cognitive treatments in bipolar. And the results indicated that pharmacological treatments have some early positive findings and could potentially help, but the most consistent findings were related to cognitive remediation. At the same time, the literature has some methodological challenges and potential for risk of bias, because in many of those studies, for example, cognition was not the primary outcome. So, how does it work? Cognitive remediation is essentially an umbrella term that is used for different treatment paradigms, which hypothesize that treatment improves cognitive functioning, which can later improve daily functioning and facilitate recovery. At the same time, though, although we have different treatment paradigms, all of them have some core principles that are the same across different ones. These are facilitation by therapists, so people have sessions with a therapist, but at the same time, they also complete some cognitive exercises, like some sort of brain training. And therapy aims to teach them cognitive strategies to improve their cognitive performance, which can later be translated into functional benefits. However, at the same time, there's a variety of paradigms, so yeah, it's more of an umbrella term. A novel approach that we're using at King's College London is called Circuits. So Circuits is essentially an online platform that includes a digital village, which patients can visit, and it also includes different buildings, like a library or restaurant, and people can often visit those buildings in order to learn things about their cognition or cognitive remediation, like the library, or other buildings in which they complete some tasks. The tasks aim to resemble daily life, so they can be things like planning someone's day. So, for example, the program gives them the task that they need to complete on that day, and whether they're time-bound. For example, I need to pick up my kids from school at 4 o'clock. And after people complete that task, the program also gives them some feedback on how well they did. The program also aims to help people set their own goals, as well as improve metacognition, so the way that they think about their cognitive functioning. And it also aims to make them more aware of their cognitive abilities and limitations. So our therapy protocol lasts 12 weeks, and it includes 30 to 40 sessions with a therapist. At the same time, in addition to those sessions, people also complete some exercises on circuits independently, so they have some homework to do. So, what do we know so far? What does the evidence tell us? A few years ago, we completed a cognitive remediation trial in people with bipolar who were euthymic at inclusion. It included 80 people with bipolar, and all of them were recruited in London, at King's College London, and we aim to assess the efficacy of circuits compared to treatment as usual. And the primary goal of this study was to assess the feasibility and acceptability of the intervention and the trial, as well as possibly get some idea of its efficacy and see if there's even a signal. The findings were quite positive, so we found that the trial was feasible. So we managed to have a quite low attrition rate, around 10%, and we also managed to collect data from the majority of people post-baseline. At the same time, therapy was acceptable, 80% of people completed it, and the overwhelming majority of those in the treatment group found it helpful. And we also found a positive effect on cognition and functioning. So week 13 is basically the week immediately after the end of therapy. And week 25, as we can see that in the diagram, is basically the follow-up. So it's 12 weeks after the therapy end. And we found small to medium effect sizes across different cognitive tests and domains during both time points, and the effects were also durable at the follow-up. Interestingly, we also found that for certain cognitive domains and tests, although the effect at week 13 was not significant, we found significant differences between groups at week 25. So this shows us that it is possible that it takes a bit longer for the effects of cognitive remediation to emerge. A possible explanation is that it takes a bit longer for people to learn certain cognitive strategies and apply them. And at the same time, we found positive effects on functional outcomes, including psychosocial functioning and the goal attainment scale. And the effects for goal attainment was large. So people in the therapy group achieved their goals to a greater extent compared to those in the control group. So we also did a secondary analysis to assess the mechanisms of CRT. and essentially see if the main hypothesis of cognitive remediation, the fact that therapy improves cognitive functioning, which can later improve sexual functioning, is true. And we found that this is the case. So we found that cognitive remediation improved global cognition at week 13, which later improved sexual functioning, but at the same time, this was a partial mediation. So there was also a direct effect of therapy to the FAST scale, which is sexual functioning. So this supports the theoretical model of cognitive remediation, but at the same time, a large proportion of its effect remains unaccounted. So further research is needed to explore the mechanisms of cognitive remediation. So, where do we go next? There have been some recent meta-analyses on cognitive remediation for bipolar, which, although included a relatively small number of studies, especially in bipolar, they found small to medium effect sizes on cognition, which is in line with what we found in our cognitive remediation trial. However, the overall effect on functioning was not significant. So, in the CRIB-1 study, in our cognitive remediation study, we found a positive effect on functioning, but the overall effect across the literature was not significant. And this meta-analysis also found that it is also possible that the effects of cognitive remediation are more pronounced during the follow-up. So again, that it is possible that it takes a bit longer for the benefits to emerge. So it's important to have a longer follow-up in cognitive remediation trials. So given the positive findings of our first cognitive remediation study, as well as the gaps in the literature, we decided to do a larger version of that study called CRIB-2, Cognitive Remediation in Bipolar 2. This largely follows the CRIB-1 methodology, but it has some key differences. The first difference is that we have a larger sample. So the CRIB-1 study included 80 people, whereas the CRIB-2 aims to include around 250 people, and at the same time we have multiple sites in England. We have London, which is the primary site, but we also have a site in Oxford, Birmingham and Newcastle. And similarly to CRIB-1, we also want to assess the efficacy of circuits compared to treatment as usual. We selected the FAST scale, which is a measure of sexual functioning, as the primary outcome at week 25. But we also aim to assess the mechanisms of cognitive remediation. So we collect some additional outcomes. These include cortisol levels in saliva, blood-based inflammatory markers, as well as some measures on metacognition and affective lability to see if these are potentially moderators of treatment response. So far, we have managed to include 204 people, the majority of whom have been recruited in London, and we have also managed to follow up the majority of them. So far, the attrition rate is quite low. It's lower than 10%, and hopefully it will stay that way. We primarily recruited from primary and secondary care services, as well as mental health charities. Bipolar UK has been extremely helpful and has helped us with recruitment quite a lot. So now that we discussed cognitive remediation, its mechanisms, we discussed the available evidence, and the implications for future research and clinical practice, it's important to go back and discuss why does it matter. And we will explore this by discussing some patients' perspectives. So, how does cognitive remediation benefit people with bipolar? Cognitive remediation aims to help them build a toolbox to solve real problems. And some participants actually told us that. They told us when they took part in our study that they wanted to improve their functioning, that although they've been stable for years, cognitively they're not the same. But they don't have the tools to improve their functioning, they don't know how. It also aims to help them regain cognitive control and minimize impulsivity. So often, people, when they need to do a task, at work for example, they tend to start doing it without thinking of the best way to do that. So they act a bit more impulsively than some other people. And it also aims to help them improve their metacognitive awareness, so be more aware of the cognitive abilities and limitations, as well as set some realistic goals with them that they can achieve during therapy. We also collected some feedback from some people who had cognitive remediation. This is a very interesting quote of one of them, who said that although they were stable for a long time, they were unemployed and struggled to look after themselves. But after therapy, they improved quite a lot, they improved their metacognition, and they were able to function better. We have another quote from another of our participants who was in the therapy group, which has been also published in the Bipolar UK website. So this person said that therapy helped them return to work and also function better, which is extremely helpful, because if someone returns to work, it means that potentially the burden of the condition reduces and they're able to function way better than before. So given that we got some quite interesting feedback from some people in the therapy group, we decided to systematically collect feedback from those who received cognitive remediation. So we will be conducting some semi-structured interviews to collect feedback on the patient's perspectives of CRT, as well as their satisfaction, which we aim to use in order to inform the delivery of cognitive remediation and potentially improve its efficacy. So, in conclusion, we have good evidence on the feasibility and acceptability of cognitive remediation, as well as its effect on cognitive outcomes. There is weaker evidence on its efficacy on functional outcomes, as well as its mechanisms. We also need more research to find biomarkers of treatment response, and to date there's no research on its cost effectiveness and long-term outcomes, because most studies had a follow-up of up to 6 months. So it is important for future research to assess whether those effects of cognitive remediation are durable, like a year later perhaps, or even longer. So, in conclusion, cognitive remediation is a very promising pro-cognitive intervention which is understudied but has the potential to address a clinical gap and reduce healthcare costs for people with bipolar. At the same time, we need more research, larger and more rigorous trials, and there's also a need for methodological consistency. So because most studies follow different treatment paradigms and use different outcomes, have different time points, it's a bit more difficult to compare them. At the same time, we need some more adaptations to potentially improve its efficacy, and we also need to emphasize its clinical utility. So when we have a bit more evidence, so hopefully after the CREEP-2 findings are published, and if the findings are positive, we need to make steps towards implementing cognitive mediation in clinical practice and offering it to more people clinically. These are the references, and I would like to thank the CREEP-2 team, Dr. Dimosthenis Apekos, who is the clinical trial manager, Dr. Rebecca Strawbridge, Anna, Rosie, Natalie, Matteo, Professor T. Wykes, and Professor Alan Young, who is the PI on this study. Thank you for your attention.